Students, today we will discuss retinal detachment. Retinal detachment is the separation of neurosensory retina from the retinal pigment epithelium. Now you can see pigment epithelium in this picture. Its causes are myopia, posterior vitreous detachment. Myopia people are those people with high minus numbers. Posterior vitreous detachment that occurs due to the vitreous liquefaction. Then there can be breaks that are created in the retina. There can be tumors, there can be adhesions and degenerations, which are the weak areas present in the retina. Can be due to any trauma, any injury to the eye. It can be due to a surgical complication. Now we will see in this diagram, this is the retinal detachment, that is the separation of retinal neurosensory layer from the retinal pigment epithelium. Now this is the retinal pigment epithelium, this is the neurosensory layer, and this in between there is this gap created. That gap is called retinal detachment with SRF, which is called as subretinal fluid present. This is vitreous cavity. Now the signs and symptoms in these cases that you commonly observe are flashes of light, which are the light spark or lightning feeling that appear in front of the eye. That can be floaters. Floaters are due to the cobwebs, which are called small bubbles, small threads, any tortuous debris that is present in front of the eye or the jelly vitreous. Now low vision is very common in these cases. This is due to the macular involvement that appears due to the retinal elevation that happens. Tobacco dusting are the small pigment red color material that appear in the interior vitreous cavity, which are released due to the margins that are present in the break or in the tear that is created, and it releases pigments and comes into the interior vitreous. Retinal breaks are present, very common, can be L-shaped, can be J-shaped or U-shaped tear that are visible. Posterior vitreous detachment, as I told, it is due to the liquefaction of the vitreous. Low intraocular pressure is very common, eye gets soft. Then there will be the retinal elevation, which is subretinal fluid that is present. Vascular tortuosity, the red blood vessels become very tortuous and very you can see here irregular. Macular folds appear, it means the macula is off and the visual prognosis is not very good. Now one by one we see retinal detachment types. Retinal detachment types can be rheugmatogenous retinal detachment, which means the rheugmatogenous means the break is must to be present in these retinal detachments. Its features are convex appearance of the retinal elevated retina will be convex. It can be vascular tortuosity, retinal breaks. These are the compulsory feature that is present. Macular folds and PVR. PVR stands for proliferative vitreoretinopathy. That is very important in predicting the prognosis of retinal detachment surgery. Can be due to A, due to B, or due to C type. Now in my next video I will discuss proliferative vitreoretinopathy or PVR and the prognosis that is linked to PVR. Now in this diagram you can see the blue area is the detached area. This is inferior break that is present, and this is the blood vessel, and this is the disc that is present. Now next type, that is called tractional retinal detachment, which is concave appearance, tenting that is visible, mostly present in the diabetic patients or in the proliferative vitreoretinopathy patients. It can be due to retinal traction. It is usually immobile and shallow retinal detachment, and the macular drag. Macula is pulled away from the site of its attachment. PVR is also very important in the case of tractional retinal detachment. It tells us about the prognosis. Now you can see here, this is the superior part of the retina that is detached. This is the vascular tortuosity present, and these are the small intraretinal hemorrhages or dot and blot hemorrhages visible. This blue mark indicates the macular area. Now serous retinal detachment, it is linked to the tumors. Now serous retinal detachment is very common and it is linked to the tumors. Whenever there are tumors, serous retinal detachment is always looked for. It is convex shaped and it is dome shaped. It is shallow or maybe bullous. Shifting fluid is always present. Very important, shifting fluid. This is the feature. You can miss all the feature, but you cannot shift the shifting fluid feature. Visual field defects very common, and PVR can be looked for. Usually PVR is not very much high in serous retinal detachments, as there are no breaks, and it is mostly linked to the intraocular pathology, that are the malignancies that are present. Treatment, how will you treat retinal detachment cases? Very important thing that you will look for in such cases is the time when the patient comes to you. Now if the macula is on, if the macular folds are not visible and retinal detachment is mobile, then the prognosis is good. Now We will see the proliferative vitreoretinopathy PVR. If the PVR grade is also low and there is no subretinal fibrosis, you can treat the case very well and you can gain very good visual prognosis. Now what you will do, first you will refer to the vitreoretinal surgeon. You cannot do all the surgeries, so you have to refer it to the vitreoretinal surgeon. You have to seal the break first. You have to do Pars Plans Vitrectomy, PPV, which is vitrectomy type of vitrectomy that we usually do 23 gauge Pars Plans Vitrectomy. Then you can do Pneumatic Retinopexy, in which we can use air, in which we can use gas, pneumosis appears. So this, it will press the retina to get its normal configuration back, so it gets attached to the RPE. Scleral Bixby, which is external approach, and you can use explants. These explants push the retina inwards and the RPA push the sclera inwards, and it gets attached to the detached retina. But you always remember the vitreous should be intact in such cases. Then the endotamponades. Now with these procedures in which we use PPV, we have to use silicone oil, we have to use a gas which is 33F8 or SF6, we have to use an air, and we can use another thing that is called PFCl, which is heavy liquid or perfluorochloro materials that are present in such cases. We have to use these cases, so these are usually heavier, so they can press the retina back to their normal shape. They can press it, and it will help us to release or to remove the subretinal fluid, and we can get attachment back. From detachment we can get the attachment back of the retina. So then we can apply the endo laser. Laser is very important. You cannot complete your retinal surgery without the endo laser. So this was the treatment that you can offer to the patients, or you can learn about the treatment in such cases. Thank you very much.